I am a consultant of Medtronic, and the second disclosure is that everything I'll speak with you about is related to research. So when we talk about anticoagulation, we really have to have a quick look at the transfusion risk, and I believe Dr. Scott and Gerard Myers have given really wonderful segues to this presentation this morning. We'll talk a little bit about heparin and the many challenges, and also have a look at heparin resistance and what we're doing today by way of treatment. And what is the best way of dosing our patients with heparin and then monitoring? There is evidence for practice, so we'll have a look at that, and the guidelines as well. So when we talk about blood management, I think we'll all agree that there is a significant amount of evidence that we would agree with clinical practice today. I have about four forest plot slides that I'll just quickly review. They are all the same format, so on the left you'll see the authors. And if you focus on the right-hand side, the far right would be papers that support patients having no transfusions, and on the left would be papers that support patients having transfusions. And this would relate to sepsis, bacteremia, or any infection. So basically, transfusion related to those outcomes is not a good thing. Likewise, this forest plot has a look at acute renal failure and renal replacement therapy, and again you'll see that the odds ratio favors patients that are not transfused. This actually looks at 30-day mortality, again favoring no transfusion. And this article was quite interesting because it actually looked at increased risk of death, renal failure, infection, prolonged intubation, hospital length of stay, etc. And of course, all also favored no transfusion. Interestingly enough, so you see the rate of mortality within 6 months in the red. So transfusions have higher risk of death. But interestingly enough, those same patients that were transfused have a higher rate of death up to 5 years out from time of surgery. So who is at risk of bleeding? Well, we've heard eloquently earlier already this morning about 15 to 20% of all products are used by patients having cardiac surgery, and the risk is still quite high even for patients having a bypass procedure. Now, there are some really wonderful programs that are leading the way with multi-modality techniques to reduce the amount of transfusion patients are subjected to. And we see patients that have longer procedures and or the use of deep hypothermia that also increase the risk. And of course, our most vulnerable patients, so the very young infants and the older patients that come to us with more comorbidities today. So what does this data really mean? Well, bleeding and transfusion is certainly a risk factor still for outcomes for patients. And an exposure to a red cell transfusion actually has a significant increase in risk-adjusted mortality. Do you hear that feedback? You do? It's irritating me. It's probably irritating you. I'll stand back a bit. So the risk adjustment actually is very important for us to understand, and it's dose adjusted. So transfusing even 1 to 2 units to patients increases their risk. And in fact, it used to be for adult procedures, if a patient was to receive a transfusion, I would hear give them 2 units, and that would be a standard dose. Whereas today, I think we're much more cognizant that we would give 1 unit, see what the result is, and if we needed more, give more at that point. So we all like to throw up these slides, and I'm not competing with Dr. Scott because he certainly did a wonderful job. I just like to remind us that in bypass surgery, we're activating tissue factor as soon as our anesthesiologist pokes the patient. So for a central line or an art line, tissue factor is activated. And of course, we're activating contact factor through our bypass systems. The point of this slide really, which was to spot us back in the early 2000s, is that as perfusionists, we really are trying to minimize thrombin formation. And we shouldn't kid ourselves, especially after hearing everything this morning, that thrombin is certainly being generated. An important thing for us to remember is that thrombin is a huge activator of platelets, and we need to preserve our platelets as best we can for after surgery when we need the patient to clot. From a research perspective, we do measure the outcome of thrombin generation through our fibrinolytic system. So we measure things like fibrin degradation products or D-dimers, and we measure thrombin antithrombin through measuring these activators as well. Again, not to dwell on this, but we all know that we certainly need a proper chain length of heparin to be effective, and we need to try and form this complex with our natural occurring antithrombin to have anticoagulation be effective. And this certainly is through factor 2A, but also through 10A. And there is a secondary action through heparin cofactor 2 as well. So our goals, of course, in bypass is to try and balance this anticoagulation process. And if we optimize the inhibition of proteins and platelets, then hopefully on the other side, we're going to minimize bleeding and thrombosis and therefore reduce transfusion. So we'll switch for a moment to variability of heparin response. So we all know that there's a huge variation in the molecular structure of our heparin, and only about a third of our heparin molecules bind with antithrombin. The remainder of heparin molecules actually go on to bind with other proteins, and these cause untoward effects. And we learned already about the huge endothelial cell area, which is where our heparin can bind, as well as to other plasma proteins, platelets, macrophages. And all of those areas we're not measuring. There's differences in heparin sensitivity, of course, from patient to patient, as well as from children to adults. And there's altered pharmacodynamics and pharmacokinetics related to what temperature we're at, how diluted we are at, as well as the organ function the patient may have come into us with. And I think we're all aware of the half-life, about half through the kidney and half through the liver. So what about heparin resistance then? We do see it from time to time. It's not that frequent. And the primary mechanism is through antithrombin deficiency. Again, our patients are coming to us in inflammatory states. They may already have some degree of organ dysfunction. They might have already been on heparin. So the prevalence in adults is quite low, maybe 1 in 3,000, so that's why we don't see it every day. And we could see levels down into the 40-60%. Of course, in small infants, this is normal, and we call that developmental immaturity. So this was a recent paper, and it had a look at low antithrombin levels before bypass and what it was associated. So we had a poor response to heparin of up to 30%. It required increased heparin doses in order to effectively anticoagulate the patient. It resulted in an anticoagulation that was less effective and contributed to increased thrombin generation. What about potency? Well, you've all seen this over the last few years. Of course, our source changed back in '04 from bovine to porcine. And then there was the whole issue of the FDA responding to the over 200 deaths from oversulfated chondroitin sulfate. So the FDA mandated two changes. The first was a quality change where they have new quality tests in order to hopefully catch any further contaminants in the future. The second was to actually establish a new potency assay or a reference standard. So our USP unit dose of heparin today aligns with potency dose of heparin by the World Health Organization. So all of our heparin should in fact be standard. In doing this new formulation, the FDA noticed that there was about a 10% reduction in the new formulation from the old, and this was reflected by a reduction in the ACT values. So they recommended using individualized heparin dosing, and certainly in small patients and cardiac patients. They also suggested that these decreases may require dose adjustments, and they picked on our patients again, ECMO, cardiac patient, pediatric patients, and those with severe life-threatening thrombosis. So there was a prospective study done, and this was following a retrospective review. And these researchers found that it certainly collaborated with the FDA's results, and they found that their loading dose required about a 12% increase in heparin with the new formulation compared to the old, and with the new formulation, only about 60% of patients were able to establish the appropriate ACT value. In pediatrics, there was similar work done, but this was a retrospective study, and they as well found that significantly more patients failed to achieve an ACT target over 480 seconds with the new formulation of heparin. So what about brand name? Well, just between two brands. So this group looked at Hepalean compared to PPC heparin. And the reason for that was Hepalean was ceased to be manufactured. These researchers found that when they switched to PPC heparin, they noticed that their patients seemed to be requiring more heparin and might have been bleeding a little more. So this was following a retrospective review, and then they randomized 21 patients between the two heparins. And you can see here that there was, in the new heparin, PPC heparin, a significantly more amount of heparin, total dose, dose per kilo, and protamine dose in the new formulation. And they also found an increase in chest tube volume loss, although it didn't reach significance. This is work that our group did. This is a retrospective study in about 900 patients where we compared the two heparins as well. And you can see that we went after the outcomes and found significant differences. Again, the PPC heparin being worse in terms of bleeding complications, including transfusions, thrombotic complications, and longer ICU and hospital length of stay. And I think I just bring this to your attention because now our pharmacies are needing to change from one heparin brand to another heparin brand just based on availability. Heparin is becoming a very hard to find commodity. And so I think just opening a dialogue with your pharmacy to say, hey, please let us know in the clinical arena if you need to change your heparin so that we can watch for any changes. So then what about dosing and monitoring? What does the evidence say to us? Well, if you think about evidence-based research, we have to go back to Sackett back in the late 90s, and he shared with us that if we do have knowledge and innovative technology, we should be able to develop standards of care and practice guidelines. So, do we practice a standard of care for anticoagulation in terms of dosing and monitoring today? I think we still have these two main divergent methods. One that has been around since the early days of bypass, and that would be using a fixed dose. I think more likely today with the weaker heparin, we're up around 400 units per kilogram, and we look for a target ACT over 480 seconds. The second method would be using individualized heparin dosing based on a heparin dose response. We still need to target the ACT, and this method uses additional information, which is the heparin concentration. And I think this is where I would like to just suggest to us that all of this research over the last 20, 30 years looking at heparin management systems and dosing using heparin concentrations, we've always compared using the ACT to the HMS. Whereas I really think we have to start thinking about when these devices give us appropriate information, because they both give us really good information. So I don't think it's really one or the other. I think it's knowing when they're effective and what information they're giving us. So what can we use to monitor anticoagulation? Of course, APTT, anti-10A, which still is the gold standard for heparin concentration, or thrombin generation. We're more likely to use ACT or heparin management system in the operating room. But what one is giving us the information that we need to most effectively anticoagulate our patients? Well, most likely from a physiological point of view, the anti-10A or measuring thrombin generation would be most effective. These, of course, are not available as of yet from a point of care perspective. So we have a look at the ACT. Of course, it's been around for a long time, and it's a very effective monitor, and there are many different monitors today and have been in the past. Well, it measures the time for whole blood to clot. It's very simple. It measures global hemostatic mechanism of the heparin effect. And it correlates well with the anti-10A, but in the pre-bypass period. So I think that's a key point there for us to remember. And our desired outcome is to give our heparin and have an ACT over 480 seconds or whatever our target ACT value is. And then to maintain that value through bypass. On the downside, our ACT, we know from many publications, is affected by other factors other than heparin. So dilution, temperature, what we put in our prime. What our patients come to us like today, and they're on various medications, they come with various states, comorbidities. Their factor and platelet deficiencies also come with them. And from a technical perspective, we know that we can't take one ACT machine and interchange it for another without recalibrating the data. There's user technique, so from one clinician to another, we vary. Activators, blood volume, temperature, etc., all affect the ACT. So elevated ACTs do not necessarily accurately reflect the heparin level during bypass. In fact, publications have shown that the ACT value may be up to 3 times that of the anti-10A if you're doing side-to-side comparisons. So what this may lead to are very low heparin concentrations during bypass, and if you're basing your protamine dose on that, very high protamine doses at the end of the case. Well, Bull and colleagues back in the mid-70s were also noticing that from patient to patient there was a variability between the same heparin dose. And so they came up with this very easy plot. So on the x-axis we take known concentrations of heparin, and on the y we look for our target ACT. And in fact we can plot individual patients' response to heparin. Well, that's exactly the methodology that the heparin management system utilizes. So we're plotting the response of the patient to known concentrations of heparin to a target ACT of whatever your value is. So we're looking at the individual patient's sensitivity to the known amount of heparin that they require to be appropriately anticoagulated. And we'll come back in a moment to talk about the slope that's generated that we just talked about, Dr. Bull's slope. So during bypass, we can do another test called the heparin protamine titration, and this is measuring our heparin concentration, which would then give us the ability to give extra heparin when the heparin concentration fell below our value to bring it back up to the measured amount that we're looking for during bypass. It also gives us a very accurate protamine dose based on the amount of heparin left in the patient at the end of the case. So the individual heparin dose response plotted, I really like to think of as the Bull curve. And this is what is developed for us through the heparin management system. And this happens in about 80% of the time. So the HMS system is not perfect either. And there were just recently 2 publications that were published that Ty was talking about from the Ochsner Foundation. And interestingly enough, there was a pro-ACT weight-based formula promoted by one anesthesiologist, and his colleague, in fact, wrote the other paper utilizing the addition of the heparin management system. So if you can get a hold of them, I have the authors for you if you like. But basically, again, they were comparing using fixed dose with the ACT compared to heparin management system utilizing heparin concentration. And I would submit to you, they're both right, but they really need to use the devices at the appropriate times. So in the Con paper, one of the arguments was that there are a few large randomized trials, no multi-center trials, so we're left with single-center trials. And that the studies don't always demonstrate significance in terms of the data, in terms of bleeding and transfusions. And I'd just like to bring this back to us to remember the transfusion data that shows us that even giving 1 unit of red cells increases our morbidity and mortality. So most HMS papers do suggest that there is at least less bleeding and less transfusions, although not always significant, depending on the study numbers. So back to our slope, and I think this is one very important attribute of the HMS system that can help us to diagnose what's going on with our patient early. So heparin resistance, so generally the definition is failure to reach our target ACT, and then we follow and do a repeat dose of heparin, and the ACT does not come up to the target at that point either. Or they will show a low heparin sensitivity index on the HMS, or this slope. So generally we think about that slope being less than about 80 seconds that may be connected to a low antithrombin level. So this is an important study that showed antithrombin treatment of heparin resistance before and during bypass in 5 adult trials. So they showed that there's an inverse relationship between post-op antithrombin levels of less than 60%. And they showed worse outcomes in all of these areas with low levels of AT, so bleeding, clotting, adverse neurological events, and again, prolonged ICU time, as well as hemostatic activation like D-dimers, F1.2, and thrombin generation like we talked about at the beginning of the talk. Well, what do we do with heparin resistance? So we actually do have guidelines through the STS available for us. And it makes sense that they support the use of antithrombin rather than plasma because these guidelines are for the reduction of blood transfusion. The next few slides I'll share with you, this is work that we did at sick kids in infants, and following our HMS study where we found that patients that had the lowest antithrombin levels required the highest amount of heparin dosing for anticoagulation. Those same patients bled the worst and had worse clinical outcomes such as bleeding, clotting, longer length of stay in the ICU. So then we randomized infants that had antithrombin levels less than 75% into receiving antithrombin before heparin or placebo if their anti-10A was less than 75%. So they had overall improved anticoagulation metrics. So you see always on the left bar is antithrombin and on the x-axis. So heparinization was achieved more effectively when antithrombin was given. The failed heparinization was half that of the control group. And the total amount of heparin, quite interestingly, which it was our earlier hypothesis, was significantly less in the antithrombin group. As far as decreased inflammatory and thrombogenic markers, again, all of the slides are set up the same way, but there is significantly less inflammation in markers such as prothrombin fragment 1.2, IL-1A, IL-1B, IL-6, IL-8, and TNF-A, all in the patients receiving antithrombin. Well, what about other clinical outcomes then? So again, just to highlight the fact that none of these are significant in terms of the statistical data. However, the numbers were quite small, so we are enrolling more patients to see if these do turn into significance once we have a higher research number. But we did see less bleeding in the antithrombin group at 4 hours, 24 hours, less red cell transfusion, and less platelet transfusion, all in those patients receiving antithrombin. Just a couple words about protamine overdose. So this was an excellent article comparing just monitoring with an ACT versus HMS-based practice. The heparin levels were significantly lower in the ACT-only group. They had much higher doses of protamine. There were hemostatic disturbances as measured by the ROTEM. And clinically, again, there was increased post-op blood loss that related into receiving more blood products. So their conclusions were that individual protamine dose guided by the heparin management system avoided overdosing. And you know, over the years, there are multiple publications that have shown us other disadvantage of overdosing of protamine and the activation and bleeding that it can cause. And we'll talk in a moment about the guidelines. They're certainly promoting giving less overall protamine. So just quickly then, 20 years of clinical evidence. These are all adult papers. On the left-hand side of the slide are the authors, the year and the publication. What's important here is that all of these patients, when they compared the ACT protocol compared to utilizing the HMS as well, these patients received significantly more heparin as guided by the HMS system compared to ACT alone, but also significantly less protamine. They had less blood loss, which translated into less transfusion. Again, on the right, many of these researchers attempted to measure hemostatic activation, so thrombin generation, fibrinolysis, improved platelet counts, This group out of Europe actually saw improved ROTAM dynamics following the HMS system. So with the HMS, then, we generally see higher amounts of heparin dosing and lower protamine compared to utilizing the ACT alone. And this results in less activation and consumption of various proteins and platelets. So that's the one thing that the research has not been able to discern is it because we keep the heparin higher, or is it because we're giving less protamine, or perhaps it's both. But just for us to remember that we certainly don't know the true mechanism. But clinically, the strategy does result in less morbidity associated with bleeding and transfusion. This is just a snapshot, same exact layout of the slide, but in children, and most of the same results. Guzetta's paper, they had a very small amount of patients, and they were both infants up to 6 months, so they were not able to see a difference. That was probably a sample problem in the study. Our work enrolled babies less than 1 month of age as well, and we showed significant improvements in clinical outcomes, bleeding, transfusion, ventilation time, ICU, and hospital length of time. And then the last paper was quite interesting. They actually did a little bit of a cost analysis and showed that utilizing the HMS system related to blood transfusion as well as getting out of the OR quicker, they saved about $1,000 per patient. So I'll just wrap up the last couple of slides to show that we do have evidence today and we have guidelines. What was interesting about these 3 publications, so the first is the STS guidelines that I referred to earlier. It was wonderful that this was a consortium of surgeons, anesthesiologists, and perfusionists who developed this. The second basically is the same but in children, published in Circulation, and the third is out of Europe. What was wonderful is that all of the guidelines basically agreed with each other. And so the recommendation is that for short cases, the ACT may be suitable, but for longer cases or more complex cases over 2 hours, they certainly do support the use of patient-specific heparin concentrations or heparin protamine titrations during the case. And remember that these guidelines are based on reducing transfusions, so their response to why we should use these point-of-care tests was to reduce activation, consumption of platelets that will reduce transfusions. The second and very important guideline is to use protamine titration or empirically low-dose protocols, so to lower the total dose of protamine or the ratio of heparin to protamine. And again, the reason for that is there are many papers now that support the use of lower protamine to reduce transfusions. Finally, we as perfusionists have our own guidelines through AMSECT, and basically they also support the other publications in terms of what we should be doing for our monitoring of anticoagulation. So I hope I've convinced you, as well as the other speakers this morning, that transfusion is an issue. We should avoid them at all costs. Certainly we do have to transfuse patients when it's important, so I'm not saying that never do it. We just have to try and minimize. We have many challenges with heparin, and I'm sure there will be more to come in the future as that commodity is more and more scarce. And if you are using the heparin management system, if you're not already giving consideration to your first sample to the slope, start to look at that, because I think that that will really start to be a key piece of information for you in terms of helping to diagnose any antithrombin deficiencies. And using the heparin management system then gives us that individual response. As we talked about, each patient does respond differently, and certainly gives us a more accurate protamine dose. So reducing mortality is important. I feel that optimal anticoagulation is one of those pieces to the puzzle that we as clinicians can help to manage, and that professional anticoagulation guidelines are a really good place to start if we need to think about this a little bit more so that we can bring up the conversation with our teams. With that, I thank you and would be happy to address any questions.